When we initially looked at regorafenib and patients who actually got off regorafenib and then were still in good shape and wanted to be treated, even outside of clinical trials, we observed that when we used agents again that had been used before regorafenib, even patients who progressed on these regimens, very regimens before regorafenib, they might have a response stable disease actually after regorafenib. I remember 2 patients actually triggered my interest in that, who had progressed on the fluoropyrimidine plus bevacizumab before regorafenib and responded really beautifully after regorafenib and quite long lasting. So we actually discussed this and looked at preclinical data and clinical data. We did a joint analysis between Mayo Clinic, MD Anderson, and USC, and did actually collect patients where there was this idea of a clinical resensitization effect. Now, we don't know yet whether this is just based on the fact that regorafenib as a non-chemotherapy drugs gives patients time off cytotoxic therapy, and just through this time effect allows clones to reemerge that eventually are sensitive to chemotherapy. It could just be a time effect. Now, the other question would be, is it a biologic effect? Because regorafenib as a multi-kinase inhibitor is involved in a lot of biologic phenomena, that really characterize cancer cells, including chemosensitivity. And there's adding regorafenib to chemotherapy, 5-FU-based, irinotecan-based, even EGF receptor antibodies that suggest there's some additive / synergistic effect, but I do believe we need to really work on these animal models more. And it's not easy to design the right animal models because regorafenib's activity could be related to various different things, including angiogenesis, inhibition, microenvironment modulation, pathway inhibition within tumor cells, but also modulation of the immune system. And all these factors are not very easy to test in an animal model, and animal models might not be fully predictive what's happening in humans.
A very important question is, when we decide to use either regorafenib or TAS-102, which is the best to use before and which is the best to use after? And I guess that we have no evidence in the literature so far that is suggesting that one sequence is superior to the other. In other words, in my opinion, my preference is more based on which are the treatment goals, which are the side effects that I would like to avoid for a patient, rather than what they expect in terms of activity or potentially of efficacy. And therefore, I treat with regorafenib followed by TAS-102 or vice versa, based more on what is the natural history of disease, how the patient was treated, which lines of treatment were given before in terms also of side effects and length of treatment, rather than thinking that giving regorafenib before TAS-102 is better or giving TAS-102 before regorafenib is better, because I don't think we have this data, and I think we will never have this data in the general population of patients.
Yeah, so I think that's an ongoing question. What is the best drug in third line? Because when you look at the efficacy profiles, they're very similar. I think in the future that may be answered because with new data coming out with TAS-102 and bevacizumab showing very nice overall survival data, as well as regorafenib with immune checkpoint inhibitors. So we may learn much more in the future what combinations we should use. In general, I think that what we learned with regorafenib, that if it is important to use it in earlier lines of treatment, as well as in younger fit patients compared to TAS-102. That's kind of what we use as a direction in order to make the most effective treatment decision and most convenient treatment decision for the patient.
A possibility then is combining TAS-102, that is a fluoropyrimidine, with regorafenib, that is a broad spectrum anti-angiogenic agent. And the question is it worth to do the two drugs together, or is better to do the two drugs in sequence? And again, it's very complex to give an answer. First of all, we need randomized phase 3 data really to show if combining the two of them is better than giving each alone followed by the other, because for sure we are putting together two different types of toxicities, and with two drugs, and most likely will be both cytostatic rather than cytotoxic. And we have to see if combining the anti-angiogenic properties of regorafenib and anti-metabolite properties of TAS-102 is worth in terms of enhanced activity and long-term efficacy.
Regorafenib has been mainly used as single agent treatment and is being, recognized as one of the standards of care. Now, regorafenib could potentially lend itself for combination therapy if there's an agent that does not have overlapping toxicity. Like TAS-102. TAS-102 has really very different toxicity profile than regorafenib. They do not overlap. So there is single arm phase 1b studies for early experiences with a combination of regorafenib and TAS-102. The data are very preliminary so far. I do believe this is an interesting combination, could be moved forward, but we definitely need to have, at this point, randomized data to show that. Other combinations are regorafenib in combination with immune checkpoint inhibitors like nivolumab, like other agents, because I believe, regorafenib is one of those drugs that can augment immune response through various mechanisms, macrophage population shift, etc., that needs to be explored further. And we have preliminary data that are very interesting.